Start at the bottom,
Okay.
and I'm gonna work it to the top like Drake.
Okay.
For this one.
It's a modern day reference that I don't get. So. It is December. Oh, were you starting? Okay, let's get started.
You go first.
Oh, that's so kind of you.
I went first last time.
Is that your Christmas gift to me?
It is.
It is December 2023. We are very excited to look at CFP Distilled once again in this video. What do we do like every month?
We're gonna summarize the clinically important articles and give you key exam tips.
Amazing. So let's dive into the table of contents. Which articles are we going to focus on today?
We're gonna talk about the CTS guidelines once again, strategies and considerations for patients with mild asthma.
So most of our patients with
Again,
asthma,
this is like the
mild.
fourth article this year on this.
Amazing. And the next one is going to be about supraventricular tachycardia.
Yeah, this is an important one. We don't see it all the time, but what are we looking for on physical exam, and what are the patient's parents going to tell us? What's next?
Bronchiolitis in infants, again, very timely this time of year.
So all kid stuff so far. SVT in kids, bronchiolitis in infants, patients with mild asthma. What are we going to finish with?
The last one is going to be about your patient has a high triglyceride level. We'll talk a little bit about a lawsuit in this area, what you need to know about one of their major risks. But first, every month, we do our cover critique.
Cover critique. So what do we have here? This is someone who has just learned about collage.
Yes.
For the first time.
It looks like a collage of collages.
collage.
We've got our happy face, the drama,
Shakespearean,
really,
different sides of the brain is I think what they're trying to get
it's
at
like
here.
medicine, there's drama, it's like my brain.
It's the first AI generated image that was ever made.
Could be, yeah. So what was the actual point? This was illustrated by Michael Fong, and it's called The Struggle Within. So actually, maybe it did meet the artist's purpose.
I struggled to interpret it, to be honest.
There we go.
So that was my struggle within.
Well, clearly we're here to talk about the science and not the art. Okay.
So what about the edit? And now, just pause for a second before we get into the article.
Oh, you really wanted to do this, eh?
The best edit of the year. This gets it for the award for the best title of editorial.
That's right. So Nicholas Pimlott.
Nicholas Pimlott, You Can't Eat Scenery. And now I get it. He goes into it as a movie and Scottish.
Why would you
a
dispute
Russian
that?
fishing boat captain in the story, but
Why would you argue that?
you can't eat scenery.
Can you eat scenery?
If you're at a floral display, it's
If
in
you
the
live in a
background.
vegetable garden. Okay.
Peter Rabbit, you can eat all his scenery.
Well, I'm going to write a letter to the editorial and explain that, yes, you can eat scenery
Eat
if
scenery
you're a resident.
If you're Peter Rabbit.
All right, so
you're a
let's
resident.
carry on and take a look at the first, flipping a lot
First
to
article,
get.
8. So you got to get to 829.
Yeah,
and so
why-
I've done something different.
Yeah,
I've
why is
done
it
something
so
totally
thin?
different. What I did is I tore out all of the advertising at the back, thick, desperate need for family physicians. And it's a much lighter, more efficient, aerodynamic, some might say, CFP distilled. Like comparing mine to yours.
It's like the CFP pamphlet.
See, you can weigh it in grams.
There's very few clinically relevant articles that month.
It's
this
a
month.
light. It was Christmas. They checked out early.
Okay, fair enough.
They're gone.
But they said, let's go with the big heavy hitters, asthma. But let's focus on mild asthma,
Mild asthma.
which is actually pretty clinically relevant. So the guidelines came out in 2019, and they had a huge change to asthma treatment for mild asthma.
So that was adding in the steroids, wasn't it?
Yeah, so the Global Initiative for Asthma said, let's use steroids for everybody with asthma, no matter how serious. In 2021, the Canadian Thoracic Society said, let's rethink this and focus on high-risk patients.
So who are high-risk patients? How do you separate them out from medium, low, high, well-controlled asthma criteria? Now, this is something, I'll put my hands up, I don't always do this. I have my set of questions I ask to figure out, is this patient high risk or not? This is nice because it codifies it.
Yeah, so we've got two great tables here. Who's at risk for a severe exacerbation and who's well-controlled. They actually say, if you ask patients, most patients in the 98th percentile are going to say, yeah, I'm well-controlled. But that's because a lot of them are using their short-acting beta agonists all the time. So what should we be asking them, Paul?
So you'd want to ask them, frequency or value of daytime symptoms, nighttime symptoms, and are they having symptoms with physical activity?
And then this one I find really interesting because there's no real qualifier other than what the patient thinks. You say, how severe are your exacerbations? And if they say severe, then it's defined as severe. And if they say it's mild, then it's mild. And of course, mild and infrequent, that's your marker for well-controlled asthma.
So this one was interesting. Sputum eosinophils. Do you ask your patients to self-assess that as well?
Do you not look at sputum eosinophils in your office? Where's your microscope, Paul? My goodness. So one of the most common questions we get at the review course, because we focus on the eosinophil count, and I love how people are this detailed, because that's how SAMP question writers think. They're focused on what kind of eosinophil count. Is it a blood eosinophil count, or is it a sputum eosinophil count? And in this case, you're right, it is sputum.
Eosinophil. So this is something I may start to order. I don't know if I'm going to order it all the time. I think by looking at, 6 of these, I don't know if that's going to be the game changer for me.
I know in our COPD lecture, we talk in this 2024 updates of the review course, we talk about how sputum eosinophils is really going to change the direction of which medications you're choosing in diagnoses like COPD and asthma.
Interesting.
So which ones of these folks are going to end up in hospital?
So assessing risk of severe exacerbation. So which are you really going to be worried about? Number 4, current smokers. So you've obviously failed in your smoking cessation. Well, I just think it's one that you might brush over as a part of the overall picture of the patient, but bang, if they're active smokers, they are at high risk, severe risk for exacerbation.
There you go. Your number 1 cause is your number 4 cause in the table. So what else makes me think this patient's probably going to end up in ER with a severe asthma exacerbation? And what do you know? Number 1 is they've had a severe asthma exacerbation.
Yeah. But that's one of my basic questions. Have you ever been admitted to hospital? Have you ever been intubated before? Instantly higher risk. And that's one of the first questions I ask when they come into the emergency room. And if they can't answer that because they're so short of breath, that's a bit of a problem. But so the number 3, I'm going to work up this list opposite from you. I'm going to start at the bottom, and I'm going to work it to the top like Drake.
Okay.
For this one.
That's a modern day reference that I don't get. So.
So overuse of SABA, and the definition they use for overuse of SABA is more than 2 of the blue inhalers a year.
Yeah, have you filled 2 prescriptions or more? More
2
than 2
inhalers.
prescriptions.
Yeah,
more than 2
2
inhalers. I'm on my 3rd one. You are likely to get an exacerbation that is severe.
So I think a lot of patients would use more. And so if you go back and if you can see their pharmaceutical history, bang, they're increased at severe risk. So so smoking and more than 2.
And then just to bring it right back to the beginning, they're high risk for severe exacerbation if they are not well controlled. And that goes back to that first list that we reviewed. Really, really great pointers for a SAMP. Bottom line, really the point of this article, maybe we should be thinking if they're higher risk, giving them steroids.
Yeah.
Now, why do you think, Paul, that these authors might be interested in increasing the pharmacotherapy of our patients, especially if, the number needed to treat is like 40 or 50?
That's really interesting. That was a really leading question. Mm-hmm. I could almost tell because I've known you so long that you have some sort of a insight or secret answer to this.
It's funny, when you go to the disclosures, there is, the authors do have pharmaceutical funding. And so I find it quite interesting that they overlook the controversy on this guideline, especially because there's in the American Family Physician Journal, they've got an article about how the pharmaceutical funding, if you follow the money, has really helped influence this as a recommendation. So I'll get the tinfoil hat out for that one.
Do you think maybe after they do the mild asthma committee, so it's CTS guidelines committee just for mild asthma, do they get promoted to like moderate risk?
I think they get promoted to the spicy asthma committee. Mild, medium, or spicy. That's how I take my chicken wings, and that's how I take my asthma recommendations.
Asthma to chicken wings. Okay, let's bring it back to something more relevant.
This is a super topic, I gotta say.
Let's move quickly through this one.
Very quickly. We're talking about acute supraventricular tachycardia, but before we do that, I do notice there's an ad for the world's second best CFP podcast. That's right. You told me not to talk about it. But
there it is. Sarah Fraser. Yeah. She came to our talk at Family Medicine Forum.
She came to the CFP.
She said she listens to us, but she's a podcaster.
Exactly. Yeah.
She listens to us, and now I want her to send us an email if she's actually listening to this.
Did she actually say this?
Have you listened to that podcast?
Moving on to the next article.
That's the second CFP Journal podcast.
All right.
Imitation is flattery.
That's true. I think we were first to market, and that's why we have the enormous listener numbers that we do.
Like and subscribe.
Yeah, why do they keep listening to us? Say. I don't know. Anyway, so...
Okay, let's get back to a learning point.
Supraventricular tachycardia.
Rand Goldman. I've never met him. Publishes a lot. Great articles.
He's in Vancouver.
Is he?
Yeah, he's at BC Children's Hospital. He publishes, my goodness, like an article or two in every CFP journal.
He must have a lot of residents to do all that work for him.
Yeah, like the two listed on this article. So what do we need to know about SVT in kids? What do those kids look like when they come to your clinic? Because they don't come in wearing a shirt that says, I've got SVT.
So what do these kids look like? So signs and symptoms in infants can be variable. They could have poor feeding, vomiting, irritability, increased sleepiness, fainting, perspiration. That's one that if a family member said to me and he starts sweating and sweating, that's one that's going to make me trigger myself to think about this.
As they get older, you're going to start to think about, the child who says, I've got, my chest hurts and I feel like my heart's thumping and I feel dizzy. And then how do the adolescents usually present?
So they come in with all those symptoms and they may also have perspiration, fatigue, and anxiety. So it can be a bit challenging to tease all of them out, but just, you got to think, if these are sudden episodes, might be on, off, could this be SVT? What are you going to do then? What's the pharmacological therapy?
Well, I think we need to be very, very focused on the first thing we try before pharmacologic. In fact, I would say, let's be specific about this treatment.
Okay, so vagal maneuvers.
Don't
Did I
be
write
vague.
that on the... What?
Don't be vague.
Don't
It's
be
vagal
vagal.
maneuvers.
Don't be vagal. Did you
Don't
say
be
that?
vagal.
Oh,
That's right. Every month, a
are
better
you going to
dad
have
joke.
another child? That's a level 4 dad joke.
Very fantastic in dad jokes. And these are effective. Over 53% of the time, these are going to knock your patient out of SVT.
And this I love because they've got one with a diving reflex in infants.
Yeah.
And you're like, but then there's like always a caveat everywhere. They're like, but it's a bag of ice that you put on because somewhere someone converted that SVT to asystole.
It's like immerse a child in
putting
water.
a child's head into water. Like, oh my
Yeah.
God, the SVT is gone.
So you
So
got to
is
put a bag
all.
of ice, but you got to make sure you don't
Bag of ice.
smother them.
Not over the nares, not over the mouth.
Exactly. Then you got other arrhythmias to worry about. Pharmacologic therapy. So yes, finally, let's talk about that. Of course, to break them out of IV adenosine, break them out of SVT, you want IV adenosine. And Paul, what kind of animal was used as the guinea
Yeah, this
pig?
I love. I know.
In this research.
A guinea pig. What sort of a guinea pig animal did they use?
It was literally a guinea pig.
But no, but they used the first animal that they used. So it was from a bull's heart, extracted adenosine from a bull's heart. I'd love to see that medical student summer project.
Yeah, but then they injected it into a guinea pig.
Into a guinea pig. Do you think that's the first time they use guinea pigs? No, it must be before.
Anyways, maybe we need a guinea
Interesting.
pig to try that on. So
But University of Cambridge medical student summer project. Take adenosine out of this bull's heart. Step 1, remove heart from bull.
back in 1929.
Yeah.
That's how we did the research. So you give a double syringe technique. Is that what you do, Paul, or do you have another?
I prefer in more rural areas single syringe technique. There's been a few articles about it. I've used this once, and it has worked. It's much cleaner in
go.
terms of getting the medication.
More convenient, half the cost
Yeah.
of syringes.
Yeah. Syringe lobby is gonna be pissed.
Just infuriating.
They're pulling
asthma
back.
medicine lobby, the syringe lobby.
Yeah.
Just a sleeper there. You just slid that in there. Didn't even notice how clever that was.
Pulling
Well
back.
done.
Yeah.
Dad jokes.
Sales
all
are gonna
around today.
plunge.
Oh
Or-
my gosh. Okay. So let's talk a little bit about what do you do next, or more specifically, there are situations in which you should not give adenosine. This sounds like an EM exam question, if you ask me.
Which is that? Oh, that's that second to last paragraph. So when can we do it? So I think there was 2 cases. So in patients with asthma, so we just talked about asthma, and in those with non-AV node dependent SVT.
Yeah, and they've always said, if they got lung disease, you should avoid giving adenosine, or if they're taking methylxanthine, because it can cause bronchospasm. But, people are going to get dyspnea based on their bronchoconstriction. Even though they've got normal airway function, the adenosine can cause bronchoconstriction. So patients are going to look like they've got dyspnea, even though it's not. It's related to the medication. So
Yeah, and then those non-AV node dependent SVTs, including atrial tachycardia, AFib, and atrial flutter. So they're not dependent on the AV node. So adenosine doesn't work on the underlying pathway.
it's so fitting that we went from asthma, a contraindication for adenosine used for supraventricular tachycardia,
Yes.
because it can cause bronchoconstriction, and the next article is bronchiolitis. Oh my goodness, it all just fits together.
ties. It's almost as if do you think they thought about that and put that in order?
I guess we'll find out in our email from the editor,
Yeah.
Sarah Fraser. She'll say, what, you think we don't put any thought into our content of our journals?
So what's the clinical question for this one? How can we as family physicians provide optimal management of bronchiolitis in infants while avoiding unnecessary treatments and investigations. That is a SAMP question written right there.
Oh my gosh, yeah. So optimal management is going to be trying to figure out, first of all, is this mild, moderate, or severe? And there's very specific criteria on those folks who've got severe bronchiolitis. And obviously if they're in severe distress, they're lethargic, they're not feeding, they stop breathing, that's severe.
That's severe. But what about mild? The Happy Weezer. That was a band,
the
wasn't it?
non-spicy Weezer.
1990s. You look like a person who would listen to Weezer.
Weezer?
Is that do you know them or no?
I listened to Wheatus, just a teenage dirtbag.
Oh, I thought Weezer was a famous band.
Yeah, they had
maybe
lots of
someone out
different
there knows.
multicolored albums back in the day. So mild, they've got no distress.
Well hydrated, mucous membranes are moist, no or mild respiratory distress. So they're the Happy Weezer. So you hear them, but they're happy and smiling and playing around.
Yeah, and so right in the middle there, a little bit of respiratory distress, that's your moderate category. So how do we support these folks? And of course, when you're studying for your SAMs, you got to think about the non-pharmacologic options. And so I love this one because there's a long list of things we can do for these folks without touching pen to prescription pad.
Yeah, and the first one, suction. Any of these commercial devices to suck that snot out of the child's
Yeah,
nose.
you're thinking
Are these satisfying?
Your
Have
shop
you used
vac,
them?
your Dyson,
Shop
your...
vac. Don't do that.
No?
No.
Hook it up to the... You don't do that for your kid?
I've seen that on Legal Medicine, not hacks at home.
Okay. Yeah, so like the little tiny, like the nose... Oh, we can't use brand names. The non-brand specific nasal blue suction device sold at Whole Foods for like $45.
Ooh, I just
like
used a McDonald's straw.
Yeah, so there's no filter. Delicious.
Oh.
Why am I always sick when my kids get sick? No idea.
But it's satisfying. I know from real life experience, this can make such a difference.
Exactly. And so what else? Make sure their fluid intake is adequate, which, it's really neat working in Canada because we don't see those kids dying of severe dehydration as often as in other countries where that's...
They may not have those resources.
Exactly, and that's what the biggest morbidity and mortality comes from with some of these pediatric illnesses. Fever management, empowering families. How do you empower families, Paul?
I love recommendations that are so vague and all-encompassing.
You are empowered. Feel the power.
No, I think it's really giving clear instructions. These patients, the parents will be tired, they'll be exhausted. I've been that parent myself. Giving clear instructions on here's what you need to watch for and come back to care, because you don't want to have told someone that stay home, it's fine, it's just mild, without giving them the instructions about here's the things that we're looking for as physicians and when to bring them in. I'm always happy to see these patients, give a bit of reassurance to their families.
And of course, most important, CMPAs always mentions in their lectures, follow up, arrange follow-up.
The interesting one for things not to do: do not measure oxygen saturation if the patient appears well and has mild disease. In an ER context, it's almost a silly recommendation. Well, is this more just for are they specific to?
It's choosing wisely. They look good. They're happy wheezers. Don't put a sat probe on them because it's just going to cause more stress. So look at your patient, not the numbers.
I think at triage that's going to happen. I think that's almost a dangerous recommendation to not be measuring routine oxygen saturation.
I think a third of the time,
because it's going to be at the triage nursing level. I think that I don't know if that's a.
I think a third of the
what's
time,
their reference? 15.
Okay. Now you're going to do a deep dive here. What happens most often in some clinics?
They reference another choosing wisely in pediatric hospital medicine.
No, that's a competitor to choosing wisely.
Is it?
Choosing Wiley, as in Wile E. Coyote.
So you should do it carefully. There's choosing wisely, choosing unwisely, and choosing wily. Sneaky that. Professor. That answer they always have.
Do not order chest X-ray scans.
They published in the Journal of Hospital Medicine
in
2013.
You were just really obsessed with this, hey?
I just think it's interesting.
Can I finish my story? So the reason that most kids get the SAT probe message is because the triage nurse says that we don't have a SAT probe for kids today, or the kid wouldn't keep it on because they're pulling it off or chewing on it.
Yeah.
So what else does choosing wisely say about here? Don't get an X-ray. Don't get routine blood work.
Do not order chest X-ray scans. Is scans needed in there? Chest X-ray scans?
I think it's one of the editing contexts for the CFP journal. Every time they mention the word X-ray, they put the word scans next to it.
Oh, interesting. Chest X-ray scans.
Ask Sarah Fraser why they do that.
Huh.
For all this time, she doesn't listen to her podcast.
If you're listening, she said she was, man. It was very nice of her to come and say hi.
Well, she'll never listen again after this one, that's for sure.
Happy Christmas.
Do not order routine blood work But there is specific times. I like how it says, do not order blood work
Unless clinically indicated. Is there dehydration, a febrile young infant? But they're not going to be, because you're going to have hydrated them. You're going to manage their fever.
And then these kids with bronchiolitis, choosing wisely, what does it say about giving them Ventolin?
Nope.
Salbutamol.
Nope.
Corticosteroids.
Nope.
Epinephrine.
Inhaled or oral. So no salbutamol, no epi, no corticosteroids.
What about
Do you see this happen in real life? I see
yeah.
it happen in the ER.
See it happen all the time.
See it, yeah.
Often before the MDs assess the patient, this gets given.
Oh,
a
interesting.
triage.
Sometimes, yeah. Triage. Once again.
Well-intentioned. I don't know if...
What about this? Do not order comprehensive respiratory viral testing.
Oh, parents love that though.
They love it.
Get
Do you
the
want
swab.
to? Do you want to know what it is?
I know what it is. I just want to know.
I won't do this all the time, but I like to know what's circulating in my community. So when the season starts, I'll sometimes offer it and order this just to see what's going around. And sometimes I've had some kids who maybe look a little bit sicker. 3 viruses.
Okay, it's playing,
3 in 1.
Playing a little bit of amateur public health there. Aren't you? Yeah, just like you did all during the COVID outbreak.
Anybody.
But that's for another
Anybody
podcast.
can do public health.
That's
Can't
for
they?
the podcast, like a band.
What?
Yeah, your amateur public health podcast.
Oh.
Just making you out to be an anti-vaxxer, which you're not. I should be full disclosure there. And do not prescribe antibiotics for bronchiolitis if you made it this
fair.
far.
That's fair.
I'm sure you're not doing that, are you, Sarah Fraser?
You're really pushing it, aren't you?
Really pushing it. Just like my patient with hypertriglyceridemia,
Ooh.
do they need a medication? And according to a lawsuit that I'm familiar with,
Oh, yeah.
they got really upset that the family doctor didn't suggest treating the hypertriglyceridemia.
So who's this? This is a young kid
This
with
is a young adult.
hypertriglyceridemia. Okay.
They had high triglycerides.
Yeah.
The family doctor did nothing. They ended up in the ICU with...
Did I ever tell you I had hypertriglyceridemia?
Oh, I didn't know that. Did you take a statin to reduce your
No,
triglycerides?
no. I actually took bacon.
Took bacon.
Yeah. So as a first-year resident, true story.
Okay.
Have I not told you this before?
Okay.
First-year resident, I went in and I had to get some blood work done. And we learned in residency you don't need to do fasting blood work for routine testing. This is for something else. It was for the military. So I'm like, I'm going to show them. So in Regina, they actually have like a 24-hour diner and bar next to Life Labs.
Oh, amazing.
So I went in at 8 o'clock. I ordered the bacon, sausage, eggs, ate that, and walked straight over as the lab opened for the first appointment so I could make it to clinic on time.
Beautiful.
Emergency call the next day. You need to start a statin now.
Amazing.
Right now. So that doc made the right call. I had to go in and explain that I literally ate bacon and sausages before blood work. You could see it like
So
emulsifying on the
you
top.
you played a publicly funded prank, is what you're saying. You committed a form of healthcare fraud, if you will.
Did not. It was $5.99 for the breakfast. That was it.
I'm pretty sure the Tommy Douglases of the world would see that quite differently.
That was his province as well. My God.
This is what happens when you get public healthcare.
Yeah.
People just throw it to the wind.
So in the end, I don't have hypertriglyceridemia, but the pig certainly did.
Fair enough. Okay. So if you suppose you'd gotten a statin,
Okay.
you would.
What's my
not-
risk? Is it gone?
You would not have gotten pancreatitis. That is the big risk we're trying to reduce. How much would that risk have been lowered? 100%? 99%?
80.
No, not even close. So it reduces your risk of pancreatitis by 0.1% with statins.
Wow.
And
can't believe
fibrates, no effect.
No effect. Okay.
Fibrates will lower your triglyceride level, but they don't lower your risk of getting
So
pancreatitis.
it's something, not nothing, but it's pretty close to nothing.
Amazing.
Wow.
That's
it for a year. Incredible.
That's
And
the
look, they
end?
even, they can't do it alone. There's a thank you
Yeah.
right there.
For volunteers.
197 volunteers who helped facilitate the fall 2023 CFPC exam.
And a lot.
They had
big-
1,645 candidate examiner interactions. What does that mean?
That sounds
Why
expensive.
doesn't that equal with 329 SAMP written examinations?
And then the 600 oral
It
examiners
should be.
they
It
needed.
should be a multiple, shouldn't it?
Well, if you want to be,
Someone got extra SUs.
I guess so.
Maybe. Interesting. I'll have to do the math on that later.
And then a big, nice ad from the CFPC begging for examiners. So
There we are.
You too could become a CFPC examiner and be very familiar with what is on the SAMs if that is to your liking.
Here we are. That was it. What a great year.
That is a wrap for CFP Distilled December 2023, and that is a wrap for CFP Distilled 2023. And for those of you, special bonus shout out to those of you who just listened to our compilation episode of all 12 episodes packed into one amazing episode.
The only way you can get all the updates by listening to us and our horrible dad jokes. Next year, we promise to improve them from a 2 out of 10 to 3 out of 10. much.
On behalf of CFP Distilled, I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon.
See you next year.